Thank you, Richard. So starting off just with some of the research activities that have been completed. The first of these was qualitative formative research, which I mentioned earlier. This was, we conducted broad brush surveys in all the 21 communities, really just to get an idea of the background of the communities, the understanding in the communities, and also the landscape, who was working in the communities, what services were there. In total, we had 130 group activities in both countries and 95 key informant interviews. Key informant interviews were conducted with various HIV stakeholders, both care providers, local HIV experts, including groups of people living with HIV, etc. And we also did a lot of observations in 13 different locations per community, mostly involving starting off with what we call a spiral walkway. It's a bit like the Pied Piper of Hamelin. People join you as you go, and you have lots of discussions all the way through the community, trying to really understand what goes on. We used a mixed methodology, including quite a lot of participatory rapid methods, and this is just some pictures showing some of those methods being done. And there's an awful lot of work and a lot of findings from this, but this really just is a summary of looking at what were considered to be barriers over here, barriers to the implementation, and also catalysts. And the barriers were divided into those that were thought to be amenable to change and those that were really not going to be amenable to change. And I won't go through them all, but you can see that we have some positive catalysts that we think will help our intervention work, but a lot of barriers that we need to address. More research activities. The population cohort, this is the large cohort that Richard mentioned of 52,500 individuals. Obviously, we've had quite a lot of preparation work, designing the questionnaires and trying to also make sure there's some consistency in questionnaires, particularly with the Botswana group, developing and testing electronic data capture systems, and initially also doing a household census in all the communities, really to define our sampling frame and mapping the communities. And again, just this is one of the maps of one of the parts of one of the communities in South Africa, showing you, really illustrating many of the communities in South Africa are quite well defined and also quite well organised with roads and structures, making life sometimes easier. This is one of the communities in Zambia, which is much less defined, you can't really see the houses very well, but very scattered houses with no addresses, no roads. And so challenges with finding the households that have been randomly selected. Population cohort has started. We recruited and trained all the teams. The enrolment started slightly earlier in Zambia than it did in South Africa, but then we had to actually pause in Zambia because the IRB changed their mind over something, so we had to have a bit of a pause while we resolved that. To date, we've enrolled almost 5,500 participants in the population cohort, which if you were doing a normal type of study, you'd be delighted, I think, to have enrolled 5,500 participants. We're worried that we're going a little bit slowly because we've got to get 52,500, so we need to think of ways to speed that up. Intervention-wise, again, there was a lot of preparatory work designing and developing a full intervention manual, and particularly the working with all the implementation partners, because PopART has been implemented through the routine health services, through the ministry, and also through the PEPFAR implementation partners, not by the study team. So there's been a lot of meetings and a lot of work to get all of that developed. We also had to recruit and train a whole army of these community HIV care providers. I think we have in both countries combined over 600 of these, and so that took a lot of recruitment and training because they also had to be trained in HIV rapid testing as well as the procedures for the study. All the data again is being collected electronically, so those systems needed to be developed. And the intervention activities again started in Zambia at the very end of last year and in South Africa the beginning of this year. Now, these are some numbers which I know you probably can't see, and that's slightly deliberate, and also, but it's really to develop, to explain a few of our challenges. So this is actually data from Zambia up until the end of March. So in some sites, the chips have been working for 3 months, but in others only a month. So it's a mixture of data. But I think you can see that we are getting through the communities quite rapidly. So we've approached households, we've enumerated over 122,000 people. And of those, we're only collecting data on adults. And this is for really sad reasons in a way, because I think we would love to have all the data for all the population, but really because this is a research study but we're only asking verbal consent, and because of federal regulations we've only ended up being able to collect the data on adults over the age of 18, although the intervention is being offered to all members of the household. So of those over 18 we have over 69,000 adults, of whom 42,000 over have so far consented to be part of this intervention and for whom we have data on. So that's quite a big group that we're missing. And the biggest proportion that we're missing are those who were absent in the house when we went there, which is about 28%, of whom 75% are men. So we're missing the men, and we need to come up with some innovative strategies to really try to overcome this. Obviously we're doing repeat visits, we're hoping we're going to mop lots of these up. But we need to consider that as we go forward. We've got a little bit of data missing at the moment that we're trying to sort out. Of those who we do have counselling data recorded, so over 40,000 people, 75% say that they have previously tested for HIV. Now that's much higher than the national figures for Zambia and higher than we were expecting. We were expecting it to be about 50%, but it's 75%. Of those who say that they've tested HIV positive, that's 14.5% in Zambia, a very large proportion of those are already in care and also on ART, which shows you, I think, that the program in Zambia does work fairly well, but also it works well to find those who are the sickest, probably. Of those who said they'd previously tested HIV negative, some refused to retest, but of those who do retest, again, we find quite a proportion who are HIV positive, who are then able to be referred into care. And so overall, of the HIV positive individuals, about 50% are in care. We also then have the group who've never previously tested. Again, we have a proportion who are still declining to test. And again, we're finding quite a few new HIV positive individuals who are referred into care. Unfortunately, it's too early to really show you any data about how many of those are referred into care do get into care and onto treatment. Our target for that is that they have to get into care and onto treatment within 3 months, and so we're just at the 3-month period to get our first data on that. But I think that will be a challenge for us as well. When we get to the clinic, how is the uptake of universal treatment, so treatment at any CD4 count in our RMA clinics? Again, I'm only telling you snippets from Zambia. In Zambia, we've had very high uptake. We've had 98% of people who we have proposed this to have accepted. But I think there's a real caveat in that, because most of those people were people who were on pre-art care before. Some of them are then the new guys coming from the community. But we were initially mopping up those guys who were already in care. And just in terms of numbers, so we've already started almost 750 individuals outside national guidelines on treatment. In South Africa, they're seeing a slightly lower uptake, and we don't know the reasons for that yet, and that's where we're really going to need to rely on lots of qualitative work to see what are the different barriers in different countries. As Richard mentioned, we've got changing guidelines in Zambia. We have just moved to starting treatment on all individuals at CD4 count of 500 literally this week. So we'll see how that changes what we're doing. We have many meetings and a lot of governance. We have annual meetings between the two teams and the teams who are not within Africa. And we have an international advisory group who've met twice and have been advising us. Obviously, we have DSMB meetings, which is a joint DSMB with the Botswana group. But also in country, we have a trial management committee in both countries who meet quarterly and involves all the key stakeholders at sort of country level. But then we also need other meetings of the on-the-ground people. We call this the implementation. So I've called it's here ZIMPT, is the Zambia implementation management team meeting who meet monthly, and we have similar meetings at districts for communities. Because, and I show you this just to show you the complexity of this study. You know, in Zambia, so I'm just talking for Zambia, we work with 2 ministries because our Ministry of Health has been split into 2 ministries. We work with 4 provincial health authorities, 6 district health authorities, 2 US government partners, 6 PEPFAR implementing partners, 21 communities, all with their own community advisory board, multiple NGOs, CBOs, and other stakeholders working in each of these communities. So the management of all the data and keeping everybody up to date and implementing at the right time and in the right way is quite a challenge. So what have been some of our other major challenges that I haven't mentioned? We have had delays, and you can see those were some of the reasons for the delays. We're hoping we've overcome those delays and now we're going, it'll be fine. We have had some quite public criticism that we haven't been addressing couple counselling enough. I think we do address couple counselling within all our households. Many couples are choosing to test together, but this has been quite a public issue and has caused quite some confusion, I would say, in Zambia particularly. Intervention challenges, I've already mentioned the issue of men, but we also are recognising that the hard-to-reach population, some of whom we may manage to reach through our household-based approach, but many of whom we may not manage to reach. So at the moment, our community working groups and our social scientists are doing a lot of work within the communities, trying to really identify the best strategies for reaching out to these hard-to-reach populations. And it may well be that although we are basing our work on this household-based approach, we will then do some specific activities with the CHIPs to try to make sure we really do reach the hard-to-reach populations. So we're looking particularly at sex work and sex workers, because many of whom we may reach in households, but many of whom we may not. And of course also in Zambia, Zambia has very punitive laws on men having sex with men, which the situation seems to be getting worse recently with more arrests and imprisonments. And so that's a population that we really want to make sure we can reach out to. We're also having some challenges, I think, with male circumcision. Our targets for male circumcision are extremely ambitious, and our service providers, really are hoping that we will generate a lot of demand, but then we're hoping they'll really rise to the challenge of keeping up with that demand. And so we'll see how we get on with that. So that's really where we are. I'd like to acknowledge all of our funders and all of the different teams and implementing partners involved, and also, of course, mostly all of our communities and everybody who's taking part in this study. Thank you.